Okay, welcome to the May PCEP, and we thought we'd focus on neurologic emergencies, and I'm going to talk a little bit about seizures and stroke today. My name is Dr. Marty Bell, and I've been a practicing emergency physician here in town for the last 23 years. Been at Peace Health, what is now Peace Health Southwest and Southwest Medical Center prior to that. It's been a great pleasure of mine to work with all of you. Some of you I don't know, but most of you I know, I've seen, and I appreciate all the work you do in the field. This is truly where it's most challenging to gain insight to what's happening with the patient and provide initial treatment and transport. So it's really important work that you do, and we do greatly appreciate it and depend on you. So seizures and stroke. I wanted to talk a little bit initially about the anatomy and physiology before we go into this, because it gives a good platform from which we can discuss the various problems that you're going to see. Neuroanatomy in and of itself could be a whole semester course, but we'll try and consolidate it into a kind of a 2-minute description. And basically, the brain and spinal cord are tremendously complex organ systems, and they provide our ability to interact with the environment. And there's paired cerebral hemispheres, a brainstem, some subcortical structures that provide pathways for both sensory input and motor output. Special senses that are critical for our enjoyment of life and perception, and our ability to avoid harm and do good for others. The vascular supply of the brain is important too, as we'll find out in terms of the treatment of stroke. And there are paired carotid arteries and paired vertebral arteries that supply the brain. And they both come off the aorta, and they supply both the anterior and the posterior portions of the brain. We'll talk about anterior circulation and posterior circulation. There is a circle of vasculature that supplies the brainstem called the circle of Willis, and it connects all these things to provide some degree of collateral flow, so that if you have an insult in one area, that you may have some partial perfusion or good perfusion and restore function. Neuroanatomical localization is important, and as we talk about this, the structure and function are inextricably linked, and certain portions of the brain, the brain, basically the right hemisphere, if you think about this simply, will control the left side of the body. The left hemisphere will control the opposite side. So it's and things cross in the brainstem, down below the brainstem, in the medulla oblongata. The symptoms a patient will have with either a seizure or a stroke are critical to this ability to find out where the pathology is and do that quickly. We have tools now that are helpful in the hospital in terms of imaging, but we don't have a specific tool like an EKG for a STEMI patient to localize the insult. With the inferior wall MI, you look for ST elevation in leads 2, 3, and F, and reciprocal changes. Well, in a stroke patient, you rely on your history and your physical exam, and that's why it's critical, because a lot of times you'll be relying on family members or caregivers, or if you get there soon enough, you may actually witness some of the initial symptoms and be able to relay that to us, so that we can kind of focus our attempt on evaluation and treatment in the hospital. So, any questions about that? And there'll be time at the end for questions as well. So we'll get into this. So seizures, specifically, the definition, it's basically abnormal neurologic function. Normally we sit here and our nervous systems, we're interacting with the environment, and we have an autonomic nervous system as well that keeps our heart beating and our lungs inflating, and we don't think about it. It's all subconscious. It's autonomic. And this is subcortical activity that's going on. And certain episodes of abnormal neurologic function can result in seizure activity. It has to be a critical mass of neurons that are involved, not just one neuron, but a critical mass of a neural pathway that will cause a seizure. And it can manifest in a number of different ways, and we'll talk a little bit about that as we go through this description. Broken up into different categories. Generalized seizures are basically activation of the entire cerebral cortex, and they can result in both tonic-clonic activity and also absence-type symptoms. Tonic-clonic are the most common that we think of when we think of seizures. They're the most dramatic. They're very scary. I mean, if you've ever witnessed a seizure, and you probably all have, I imagine. If you haven't, you will. And these can be quite dramatic and cause a patient to look like they're going to have some great harm come to them. The tonic-clonic generalized seizures are characterized by a sudden loss of consciousness, and then they'll have a tonic phase where they have rigidity in their musculature, and they may have apnea. They definitely will have apnea and cyanosis, and they may salivate and be unable to control their secretions. They may have uncontrollable loss of bowel or bladder. And then they'll go into another phase. Oops. Are we not picking this up?
Yeah, that was my bad. Sorry. I screwed you up. Sorry about that. Should work now.
Do we start over or what?
No.
God, no. Okay, so back to the show. The tonic phase is followed by a clonic phase, which you've all seen and characterized by the uncontrollable jerking movements that be present in all the extremities. Typical length of a generalized seizure will be anywhere from a minute to a minute and a half, and then there's a postictal period. This is a classic generalized tonic-clonic seizure where there's a postictal period where the patient may be flaccid and unconscious or kind of very lethargic and confused for a period of time and then come out of it. This may be short or it may be prolonged depending on the patient and what their medical history is and what kind of medications they're on. We had a good example of this just the other day in the emergency department. We had a neuro day in the emergency department. I was putting together this talk, so I had a stroke, seizure, and TIA, and then we had some brain trauma. So an absence seizure is kind of a strange phenomenon, but it lacks this tonic-clonic activity, but we'll still have, it's kind of a generalized experience too, where there's a sudden loss of consciousness without loss of postural tone, for those of you who are taking quizzes. And it's kind of a patient that'll be kind of absent or staring into space, kind of not aware of their surroundings and unresponsive to your beckoning, and then they'll come out of it and be conversant again and aware. Partial seizures, unlike general seizures, are localized to certain specific areas of the brain, and this is where that neuroanatomical localization comes in handy and helpful. The patient I saw in the emergency department the other day presented with she was a lady that I think is well known to some of you, that had been working in Safeway and had a sudden onset of a seizure activity. But when she described it to me after her postictal phase, she said she had an uncontrollable movement of her left arm that that seemed to come out of nowhere. She was using a scanner to inventory some stuff, and then she felt worse and had got back into a coworker and sat down, and then had a generalized seizure, which was followed by a post-ictal period. And she arrived in the emergency department. A lot of these patients will arrive in their post-ictal period in the emergency department. So we go, well, what happened? So the description that they give and that you give us is critical to finding out what's going on. So she had focal symptoms, and she happened to have a previous neurologic history. She had had a stroke and had a right MCA distribution ischemic stroke related to a carotid artery dissection. And she had had a stent and done really well. I mean, she regained pretty much normal neurologic function. But when we scanned her, there was an area of encephalomalacia, or a kind of brain that had been damaged from the ischemic stroke in the right hemisphere. And it served as a nidus, or a firing point for this first focal seizure that became secondarily generalized. So the description here is pretty illustrative. The motor cortex is basically in the parietal lobe, the precentral gyrus. The motor cortex usually involves unilateral extremity movements. The frontal lobe focus, tonic head and eye deviation. The frontal lobes are also involved in a lot of emotional effects. Sensory cortex is a posterior, post-central gyrus in the parietal lobe. Can give you sensory symptoms. Occipital focus, of course, is the visual cortex, and you can give visual symptoms. And temporal lobe is it will give olfactory or gustatory hallucinations, which is quite interesting. They can be complex too. These partial seizures, where you can have different odd behaviors, automatisms, visceral symptoms, hallucinations, and seemingly mental health type symptoms. So it's in the differential of patients with altered mental status and odd behavior. And you want to really look and see if you have any evidence of any other secondary findings of seizure activities, repetitive movements, or eye deviation, or something odd. Breakthrough seizures are basically defined as recurrent seizures in known patients that have epilepsy or seizure disorders. And in reading about seizures, there's a whole kind of interplay between excitatory and inhibitory factors that either permit or inhibit seizure activity. And drugs are helpful in epileptics in elevating the threshold for seizures, and sometimes the seizure threshold is lowered by inadequate drug therapy, or things like fatigue, or other drugs that may lower the seizure threshold, as we'll talk in a minute. So we often see patients with breakthrough seizures, and we think about the differential of things. A lot of times it's non-compliance with medications. Patients may be using alcohol or drugs, and not taking their medicines right, and not following through. Sometimes it'll be, their metabolism changes because of some other drug that they're taking, a medication interaction, or dietary effects. Sometimes they just haven't had enough sleep, and their threshold is lower for seizures. Alcohol is a big deal, and you can get both alcohol-related seizures in patients that have known seizure disorders, or alcohol-related seizures due to alcohol withdrawal. And we'll talk a little bit about that. There's a list of drugs here that may lower the seizure threshold. I remember when I was in the Navy, I went to medical school and took a Navy scholarship and trained in the Navy down in Balboa, but got stationed overseas after got a billet in Yokosuka, Japan. For those of you know, Japan, south of Yokohama. and was stationed there for a couple years. And there was a patient that I saw there that came in with generalized seizure, and it was actually a toxidrome. It was a lady that had taken an overdose of isoniazid or INH for, it's a treatment for tuberculosis, basically, and that is known to cause seizures. And the antidote for that is vitamin B6. So we had to kind of scurry around to get all the vitamin B6 we had. And as I remember it, her seizures were controlled, and with a combination of benzodiazepines and vitamin B6. So tricyclics, you can have seizures. I had another case when I was a resident, just learning about tricyclics and how dangerous they are. I mistakenly had given a patient that was toxic on tricyclics some charcoal. It was back in the day when we were doing gastric lavage and charcoal, and she, in the course of giving her charcoal a minute or two later, she had a generalized seizure, and there was charcoal plastered all over the room. So, let's see, what are the other ones? Theophylline, that's a drug that is kind of a historic drug. We don't see too many patients on it anymore, but that in high doses and toxic effects can cause seizures. Differential diagnosis for seizures. There's a wide differential, and sometimes it's hard to sort out. We had a wonderful little, I don't know if you've all seen this thing, the YouTube video on pseudo-seizures with these animation characters that this girl that comes into the emergency department and is doing some kind of strange dance moves and, telling the doctor that she's having a seizure. And no, it wasn't a seizure. It was a pseudo-seizure. And patients can be quite convincing and with pseudo-seizures because they know, some of them have seizure disorders and have pseudo-seizures. So it's hard to sort out sometimes. We all, we have to take them seriously and rule out the life threats and the organic problems before we focus on functional problems. But pseudo-seizures are a real entity. Syncope, of course, sometimes you can have a seizure in association with syncope if you have, cardiac arrest, low brain perfusion, and you have a watershed phenomenon where the areas of the brain are not perfused. You can have a brief generalized seizure or convulsion. Usually it's not a prolonged continuous tonic-clonic seizure like a true seizure, but that can happen. Hyperventilation syndrome. I mean, you can get odd behavior. We had a lady the other day that was really anxious and had classic carpopedal spasm, and was tingling all over, and you think about stroke and that, but this was hyperventilation due to anxiety. Movement disorders are basically kind of things that you get with drug toxicity, like extrapyramidal movements that are uncontrollable, tongue deviation, with Haldol, and you can get some of these extrapyramidal effects. Migraines, especially complex migraines, can sometimes present with stroke-like symptoms, and they can be very hard to discriminate, and sometimes they can actually have ischemic strokes with severe migraines. So it's something to, even in a patient with known migraine with severe symptoms, paralysis or sensory findings, and or eye findings, then it's important to treat them just like you would a stroke. Narcolepsy is a sleep disorder, and that is something that is very interesting, kind of whole area of specialized study. Sleep disorder. I was an undergrad at Stanford, and I took a course on sleep and dreams. Can you believe that? Sleep and dreams. And there was this famous sleep researcher. They had a whole kind of the groundbreaking research in sleep disorders was done there, and so narcolepsy and sleep paralysis and things like that are known entities that have to be considered in the differential diagnosis. So key points in kind of sorting out whether this is a seizure or not. You may not be able to tell, but typically they have an abrupt onset and termination. They'll have lack of recall, except for the simple partial seizures that don't affect the mentation. Uncontrollable movements, presence of a post-ictal state following this ictal state, so post-ictal and ictal. Loss of bowel and bladder control, tongue or lip biting, those all go with a kind of a generalized seizure. So we had to cut this presentation down by a number of slides, and there were like 6 slides on neurocystic cirrhosis. And it's a neurocysticercosis is a parasite, and it's important because it can be associated with seizures. It can cause areas of the brain that have abscess and chronic scarring and seizures, and it's a pretty common cause of epilepsy in the developing world. So with immigrants into the country, especially from South America, they may have seizures related to this. Neurocysticercosis. If you can spell that and say it, you're better than me. Pregnancy, and this is a big one. I mean, this is a scary situation, and we've had a few patients with eclampsia. Now, there's a preeclampsia, which precedes eclampsia. Eclampsia is basically just having a seizure in the setting of a pregnancy and preeclampsia. And preeclampsia is a complex phenomenon that involves usually women in their third trimester of pregnancy, and they get hypertensive, edematous, they get proteinuria, they get hyperreflexic, and these are all monitored as patients are treated in their third trimester by specialists in the hospital. But if there's somebody that has no prenatal care and has first pregnancy and comes in that is edematous, and then you notice that their pressure is a little bit up. It may not be dramatically up, but for a pregnant woman, it should be, normally a pretty low blood pressure, but with even a moderate or certainly a high blood pressure, it should give you an index of suspicion for preeclampsia. They can get headaches, blurred vision, confusion, hyperreflexia. We mentioned that, and one of the treatments that they give in the hospital for this is magnesium, intravenous magnesium, and they monitor the effect of magnesium by checking reflexes and on an ongoing basis to make sure that things are therapeutic. Epigastric pain, and definitive treatment in this case is delivery of the fetus, and that is usually helpful, but not completely helpful, because we can have a condition of what is called preeclampsia, postpartum preeclampsia. Postpartum preeclampsia doesn't really seem to make sense, but you can get these same symptoms that progress even a month or even 6 weeks later, sometimes even longer, and you can have seizures, eclamptic seizures. So that's in the differential. Anticonvulsant dosing regimens may be altered by the pregnancy state, so they have to be monitored closely. Compliance has to be monitored in patients that do have epilepsy, and usually this is a high-risk pregnancy with a patient with known seizure disorder. Of course, seizure episodes cause significant hypoxia to the mother, and even more hypoxia to the fetus, so it can be devastating. We don't want a patient that is pregnant to be seizing. We don't want any patient to be seizing, but especially a mother. Okay, we never see this, do we? Alcohol abuse-related seizures. Okay, seizures associated with alcohol abuse. So there's a wide variety of ways this is going to happen. An epileptic that's taking medication, they can miss their dose or not take their dose because they're just intoxicated. They can have co-ingestions that they take other drugs, and they may have a head injury from a fall or some kind of a mishap. Sleep deprivation, if you're homeless and getting moved from place to place and drunk, and you may have a lower seizure threshold than your average citizen. Electrolyte abnormalities, of course, a lot of these patients are malnourished, and they'll have magnesium deficiency and other electrolyte abnormalities. Alcohol withdrawal syndrome can be very dramatic, and it can result ultimately in what we call DTs, or delirium tremens. And that usually doesn't happen immediately, but it happens over a course of time, and it usually peaks in kind of the 3 to 5 day range after cessation of alcohol. Some patients with chronic alcoholism, with walking around with blood alcohol levels in the 4 and 5 range, can have alcohol withdrawal when their blood alcohol level hits 0.3. So it's just a kind of a relative decrease in their alcohol level, and And these are really difficult to treat and can be life-threatening with DTs. They get disoriented. They can have, severe delirium, and they can be quite impressive, and need mega doses of benzodiazepines on a regular basis. The status epilepticus is a term that is, we used to kind of define it differently, but it got very cumbersome. And what it is basically is recurrent seizures without any interictal state, and or a prolonged seizure. It can be a non-convulsive status, and that's what I was talking about earlier, about looking for other signs that may give you a clue that this is a seizure state, not just altered mental status from some other cause, because if you don't consider it, then you won't be treating it appropriately. So they may have subtle findings, like I said, altered mental status associated with things like nystagmus, twitching in the face, hands, feet, eye movements, little things like that may give you a clue. Epilepsia partialis continua, that's a repeated partial seizure, so a kind of a repeated seizure in a focal area without loss of consciousness. And continuous absence seizures, that absence state, that strange kind of state where patients don't seem to be aware of their environment. Refractory status epilepticus, think about these things with continuous seizures: structural lesions, anoxic injury, metabolic encephalopathy, and CNS infections like HSV, herpes, encephalitis. So here are some of the consequences of prolonged convulsions. You can have actually permanent damage to the neurons, aspiration pneumonitis, we've seen that, rhabdomyolysis, which is basically the muscle death in the setting of prolonged muscular activity, lactic acidosis that goes along with that, non-cardiogenic pulmonary edema, so hypoxia, severe hypoxia that's generated because of a neural reflex causing pulmonary edema. And when you intubate, you may see like frothy sputum coming up. You've seen that before probably. Cardiovascular collapse, respiratory failure that may require respiratory support. This is really significant, and I think important to understand that the mortality of status is pretty high, up to 22%, and as high as 65% for refractory status that doesn't respond to treatment. Usually if treatment is initiated early, like when you arrive and see them and get a line in or an IO in or get treatment started, you can get it treated pretty effectively with benzodiazepines. Yeah, but as time goes on, it's more difficult to treat. Head trauma, we see this in our trauma patients. You can have seizures related to trauma. They can be either immediate after the traumatic event due to kind of a sudden depolarization of neurons. We see this in contact sports sometimes, and blunt head injuries. Treatment is basically the same as our approach to the trauma patients with the ATLS approach, and also additional treatment with anticonvulsants as necessary. Usually they're a single seizure that don't tend to be prolonged. You can have early post-traumatic seizures within the first week of trauma, and these are typically due to injuries of the brain, contusions or lacerations. We see a lot of bruising and bleeds, and with open wounds you can get lacerations from the penetrating injuries. Treatment typically is anticonvulsant treatment therapy in addition to intervention or surgical procedures if necessary. And then late post-traumatic seizures can occur later after you can be remote from the injury and have a pretty high risk of recurrence and require long-term treatment with anticonvulsants. So treatment. Now, this is what you do. Basically, you want to arrive on the scene and see what you can do to protect the patient from any further injury, and position them to prevent aspiration because they're not really in control of their airway and secretions. It says no bite block here, but one way to get an airway open is to use a nasopharyngeal airway rather than a bite block. And then suction to clear their secretions. Airway adjuncts we talked about a little bit. 100% oxygen, especially in that, they really get hypoxic in that tonic phase, and will require 100% oxygen until they're breathing spontaneously and are able to oxygenate again normally. And then, of course, if the seizure persists, you want to get access, if you can, with either IV or IO, and check a glucoscan early on to see if this could be related to hypoglycemia, because that is a cause of seizures, hypoglycemia, a metabolic cause. An EKG, if you can. I mean, it's hard to get an EKG in a seizing patient. Too much artifact, you really can't interpret it very well, but that's in the protocol. Glucose in the form of D10, I guess now. It used to be D50, but now it's D10, and repeat as necessary to get the blood sugar up. Versed is a benzodiazepine, and we use more Ativan in the hospital, but Versed in the field, the dosing there for both adults and children to control the immediate seizure activity, and it'll probably elevate the threshold for further seizure activity down the road. The one problem is with giving too much benzo. Of course, you can suppress the airway and require bagging or intubation. Thiamine there is somebody if somebody's very malnourished or alcoholic, 100 milligrams of thiamine. We used to try to give that before we gave anything else because of the risk we thought of inducing Wernicke-Korsakoff syndrome, and that was just kind of not proven out to be true. Magnesium is another drug that's in your arsenal to give, especially for alcoholics and in the eclamptic patients. Now, in the pre-eclamptic state, they give larger doses of magnesium sulfate. They give like 4 to 6 grams to load them, and then they give a couple grams an hour, I think, as a maintenance dose in pre-eclamptic patients. So 2 grams over 5 to 10 minutes seems like a reasonable place to start. So we talked about being prepared to manage respiratory depression. You're experts at that with bagging and intubation if necessary. We a lot of these patients will not need to be intubated. Intubating a patient actually commits them to a longer hospital stay, and you have all the potential consequences of intubation, trauma to the airway and barotrauma to the lungs and that sort of thing. So if it's possible not to intubate and just supply oxygen or assistance, that's a great way to go. If not, then you have to make the commitment and do a definitive airway. It mentions seizures may be a sign of cerebral hypoxia from a cardiac arrest, so that's where that EKG comes in important, to just kind of screen for a rhythm disorder or a STEMI. And there may be seizures, and there may be dysrhythmias that are caused by seizures. Febrile seizures is something we see commonly in kids, and they're usually brief and associated with a peak or a change in the temperature, and they can be pretty dramatic. Sometimes they can be status too, though, and can be continuous. And we've had some kids that we've had to transport and start on other anticonvulsants in addition to benzos to stop their seizures associated with fevers. Preeclampsia, toxemia, pregnancy, and we talked a little bit about this. Hypertension with a mild state, hypertension, edema, and weight gain. It can be moderate to severe, and their blood pressure can go higher, up to over the 160 to 110, over 110, associated with Other symptoms that are concerning, neurologic symptoms, epigastric pain. They can get this thing called the HELP syndrome, which is associated with preeclampsia. It's a hemolysis, elevated liver enzymes, and low platelet count, and that can predispose to bleeding and other significant problems during the course of pregnancy. So pregnancy is a very complex operation and fraught with all sorts of potential problems. Eclampsia, we talked about that, a seizure after in a patient that has been preeclamptic. Treatment, basically oxygen, IV, cardiac monitor. Versed is something you want to start with, and then magnesium, as we said, is kind of the definitive treatment in this particular set of patients. Okay, so that does it on seizures. Are there any particular questions that I can take out of this section? Then we're going to go into stroke a little bit. We gave a grand rounds at our recent at our medical staff meeting and talked a little bit about stroke care and what we're doing now and updates in stroke care, and I thought I'd bring that back to you. Any questions? Seizures? Okay. So we'll go on to stroke. And so the stroke is important. Actually, Dr. Basson is one of our stroke neurologists, and Dr. Shano is one of our interventionalists. He's a neurosurgeon. And we kind of tag teamed in this presentation of the medical staff. And so I kind of brought a certain portion of their presentation into what I'm bringing to you today. Stroke is significant, and it's the fourth leading cause of death in the U.S. and leading cause of long-term disability. There's almost 800,000 strokes every year in the U.S. And there's a significant number of neurons that are lost each minute a stroke goes untreated. So that's the impetus for aggressive approach to identifying and treating stroke patients. There are options for treatment now in this day and age. It's typically caused the ischemic strokes, and we're kind of talking more specifically about ischemic strokes here rather than hemorrhagic strokes. Hemorrhagic strokes are a whole nother talk. And this is basically brought about by a sudden clot that forms in the artery and in an area of the brain and causes decreased perfusion. And the way we typically treat that now is to either dissolve the clot or remove the clot. And IVTPA is the kind of standard benchmark drug that is used to dissolve the clot. And we try to get it started within 60 minutes of the time the patient arrives in the emergency department. But there's a time window in which it's most effective, up to 4.5 hours in patients. We had a cutoff for 3 hours earlier, but we found that there were some patients that would benefit at a longer time window. And so it is fraught with risks. The thrombolysis can cause bleeding, and you can get a brain hemorrhage or hemorrhage elsewhere that can be devastating. So we need to really stratify these patients and select patients appropriately. The farther out in the time window they go, or the bigger the stroke is, the more risk they're at of having a hemorrhagic conversion after giving TPA. The mechanical thrombectomy procedure doesn't put patients at risk for that bleeding episode. That is a consequence of TPA. So this is a good thing to do in other patients that may not be candidates for TPA if they're outside of that window, or if they have other factors that would contraindicate giving TPA. And this is kind of a list of the best practices in stroke care. Advanced hospital notification by EMS, which you all do every day. Rapid triage and stroke team notification, which we do in the ED after your notification. A single call activation, which basically one call gets everybody. Stroke tools are basically tools we use, packets of information that we use as documentation tools and to follow patients through their course of care from both, the time they hit the ED until the time they are through with their rehabilitation. Rapid access to the CT scan, because that's basically our critical tool in sorting out these patients to define whether it's a bleed or not a bleed, and how big the stroke may be, if they're at risk for getting hemorrhagic conversion, just based on the initial non-contrast CT scan. And then the rapid interpretation of that scan, because not everybody can interpret it. It's quite complex. A radiologist may or may not be sophisticated enough to bring out or find subtleties in the scan that would be important to know in terms of deciding which type of treatment to give. And we have special neuroradiologists, so they've done fellowships in neuroradiology, so they primarily focus on these particular things, both like ischemic strokes and bleeds and tumors and things like that. So, and we do have those available to interpret these images. Rapid laboratory testing, just kind of speeding our laboratory process, because we need to know whether the patients coming in are significantly low on their platelets or anticoagulated already. A lot of patients are on either Coumadin or other medications because of heart problems, rhythm disorders, what have you, and they come in and we need to know whether they're at risk for bleeding right away. So it's important to get that from the history: aspirin, Plavix, Coumadin, Pradaxa. All those things are important in our decision making. And then rapid access to TPA. Typically, it's kept in our pharmacy, and the pharmacist will be mixing it up as soon as we pull the trigger. Team-based approach. We do that both, all the way from the pre-hospital arena to the cath lab and beyond. And then prompt data feedback. And we try to do that in our meetings and get feedback to everyone that is involved in stroke care. This is kind of a depiction of the volumes that we have year to year, and you can see it's in the 700 to 800 range for stroke volume, and there you can see the breakdown, and predominated by ischemic strokes, and the hemorrhagic strokes they're much smaller, but a significant portion. Usually it's about almost 90% ischemic strokes, and then you can see the small bar is the small light bar is TIAs, and that's transient ischemic attacks. And TIAs are important because there are patients that are at higher risk than your average person of having a completed stroke. So we take those quite seriously, especially people that have other comorbid problems like diabetes and are older. They're at higher risk for having strokes soon. So we kind of accelerate their workup to find out if they have anything that needs to be intervened upon in terms of treatment. So how are we doing? We're doing pretty well. We're not where we need to be, but we're doing better as time goes on, and we need continuous feedback and self-examination and scrutiny to make improvements, because we're not perfect. We're humans. We make mistakes, and in your everyday life, I'm sure you kind of kick yourself once or twice for making a mistake you probably shouldn't have done. But we try to put these things in place so it's a system that we can rely upon that's not so dependent on the human factor, and we rely on our colleagues as well to give us feedback in terms of communication and accept that feedback if we're doing something incorrectly, and to make it correct so that we can, for the benefit of the patients. So what our numbers look like is that 47% of the patients treated with TPA within 60 minutes. The average time decrease was 46 minutes since 2010. So that's pretty significant. We want to be able to get, by the time they get to the ED, to the door, if they're a candidate for TPA, we want them to have the drug infused within 60 minutes. Door to puncture time has to do with neurointervention, and that has to do with getting a catheter up and treatment for patients that are outside of the window for TPA or have contraindications to TPA, who have a ischemic stroke that may benefit from intervention. And the benchmark there is with 90 minutes, and our average time decrease has been 58 minutes since 2010. So that's improved, and but still we have cases where we could do better. So from an EMS standpoint in stroke, we have the American Heart Association and American Stroke Association guidelines, and you're all familiar with this, the stroke chain of survival with rapid recognition of symptoms. And this is a key to success. Public education is really critical in this, in kind of triggering the dispatch call, the identification of symptoms early on. And then rapid EMS dispatch, and then transport and pre-arrival notification so that we know if a stroke patient may be coming in. And then rapid. We actually stratified it because unlike STEMI, where you can actually see the patient is having a heart attack, you may not know if this is a stroke or a stroke mimic when you're in the field. So you call it as a stroke, we call it a code 3 stroke, and once they get into the ED, then we may, if we truly think this is the real deal, then we'll do what we call a Neuro 911 upgrade, so that we'll activate all the systems that follow, so that we can give the drug or go to the cath lab. So you want to have a low degree or a high degree of sensitivity in the field, so that you're picking up all potential stroke patients, and it may be some that have other conditions that are mimicking stroke. And then we want to be more specific when they hit the ED, and get the specific patients that will benefit from specific intervention. And then here's the 8 Ds of stroke care: detection, dispatch, delivery door. Data has to do with all the things that we do, the diagnostic imaging and the lab tests, and the more specific exams. And decision, which therapy, we talked a little bit about that, the choice of therapy, drug, and disposition. We have various tools to kind of monitor our patients' neurologic function. GCS, of course, you're all familiar with in the setting of trauma and their level of consciousness, and we have the Cincinnati pre-hospital stroke scale that you use in the field, the FAST type mnemonic, facial droop, arm drift, speech, and time at which, and this is critical, the time that you determine that the patient had onset of symptoms. Sometimes this is difficult, and sometimes it's more simple. If you have a patient that has somebody that's witnessed the event, it's incredibly helpful for us to determine the time of onset, because that's our time zero. And this is just a review of kind of a consolidated bullet point form of the Clark County stroke. I misspelled. I left a letter out of stroke there, so it's not the Stoke response; it's the stroke response protocol. Supportive care, the assessment, the Cincinnati pre-hospital stroke scale score, time of onset, whether it's witnessed, last known well, or whether it's a wake-up stroke, and then triage to the stroke center. And then, of course, you want to do your standard treatment to establish IV and provide oxygen, cardiac monitor, check their glucose, make sure they're not hypoglycemic. That's a stroke mimic. We all know about it. 12 lead EKG to rule out a STEMI. And that's important, too, because sometimes patients can have strokes in the setting of STEMIs or rhythm disorders. Atrial fibrillation is classic for cardioembolic stroke. Sometimes you can have a dissection of the aorta. I mean, this is all in the differential, a dissection of the aorta, where you get a STEMI because of blockage of the right coronary artery, and you get a dissection around the arch where it gets the carotid arteries as well, or the vertebral arteries, and causes a stroke. And that'll be characterized by changing symptoms over time, and that's something that you'll be able to pick up. And then the witness, it's important to get either a phone number or bring the witness so that we can get an accurate idea when the time of onset was. So here's a destination procedure for EMS, and I believe you're all familiar with this. And this symptom onset, 3.5 hours, was determined because the window for treatment, once they arrive in ED is up to that 4.5 hour window. And we have 2 stroke centers in the Clark County, and but we're the intervention center at Southwest, where we can actually do neurointervention. So let's see. If there's a suspected bleed, then they should come to Southwest. If their symptoms are more than 8 hours, they can go to either facility. Symptoms between 3.5 and 8 hours to Peace Health Southwest, and then 3.5 hours or less closest stroke center or patient or family choice. Now, patients over 80 years, poor patients over 80 years, they've lived a long life, and we've seen that they don't benefit from intervention after 80 years. The more harm is done than good, and so we've kind of limited our age to 80 years old in terms of doing catheter-based intervention. In the ED, this is one of those other scales that we use. We talked about Glasgow Coma Scale. We have the Cincinnati Pre-Hospital Stroke Scale score, and then we have this NIH Stroke Scale score flow sheet, and we'll do an initial NIH stroke scale score when the patient hits the door, and then we'll monitor over the course of time as we do reevaluations, so that we can get an idea of whether the patient's status is changing over time. And the larger strokes with higher scores will benefit from treatment. If they're a real high score, though, they may have a significant risk of hemorrhagic transformation. So the other thing we have is these kind of we worked out these ways to speed the evaluation and care. So we got these order sheets that allow us to upgrade and get a rapid CT and a CTA of the head and neck, an angiogram of the head and neck, and also the appropriate labs in a panel, so that it's kind of a system way of just getting the things done without having to think about it too much. And then there's some tools that we use, as I said, to monitor patients and make sure their treatment is optimized. This has to do with glycemic control, and we want to make sure that their blood sugar is not too high or not too low, and blood pressure management. Same thing there, that you have to have adequate cerebral perfusion pressure, and you want their pressure in a reasonable range. And if it's too high, then we want to bring it down, and it depends on whether they're thrombolytic or non-thrombolytic candidates to some extent. This is another little form that we use that helps us to discriminate on patients that would have contraindications to intravenous TPA, history of bleeding or recent stroke, major surgery, GI bleeding. Some of those things are absolute or strong contraindications, and then there's some relative contraindications. We try to discriminate who would benefit and weigh the risks and the benefits, and talk to the families who, if they're there, to kind of make the best possible choice for the patient, because it's a huge choice, and the benefits of giving appropriate treatment and getting a patient back to a functional level, restoring sight or movement or other function is on the line. So these are kind of our guidelines for time, and usually in the 0 to 10 minute, you guys are bringing the patient in, and we want the doc at the bedside to basically see the patient and get your report, and do a quick physical exam, and do a first NIH stroke scale score, and then make sure that all the other things are being done or have been done, establishing IVs, monitor, and make sure oxygenation is okay, obtain 12 leave if it hasn't already been done. Usually we get another one when we're in the department, just because the field ones are sometimes a little bit of artifact on it and that sort of thing. We have a hard copy that we can keep in an electronic system that way. And then within 11 to 25 minutes, we want to transport the patient rapidly to CT as quickly as possible and get the images done to make a determination of whether they're going to be candidates for intervention. And then the 45-minute window is for the results to come back from the neuroradiologist so that they can tell us whether or not it's a good patient to do thrombolysis on. And then the 60-minute window we talked about for the door to drug to start treatment. And that's when it's most effective. And then the 90-minute window to those patients that do get TPA and don't get better, or don't get TPA and are candidates to go to the cath lab. Okay, so the last thing I wanted to talk to you, at least in my section, the ED, is stroke mimics, and these are kind of interesting because they can really make life challenging for you. So migraine or complex migraine headaches can sometimes present with stroke-like symptoms, weakness, sensory symptoms, visual symptoms. Seizure, we talked about that. Postictal paresis or Todd's paralysis. Sometimes these patients can have a focal weakness after a generalized seizure. A mass lesion, tumor, abscess. I remember one guy that came in that had a kind of poor guy that had no medical care, and he wasn't homeless, but he was kind of living a pretty solitary life, and he had some dental abscesses that he had resorted to pulling his own tooth at home like a week or two prior, and he presented with stroke-like symptoms, altered mental status, and had cerebral abscesses on CT scan. And I don't believe he survived. It was pretty bad, but it was something that can mimic strokes. Those mass lesions. Hypertensive crisis, encephalopathy. This PRESS is basically a posterior reversible encephalopathy syndrome, and it's basically patients that have a hypertensive crisis. They can get visual symptoms, blindness, and that sort of thing with real high pressures. Head trauma, we've all seen this, and as a consequence of subdurals, epidurals, or other causes of intracranial hemorrhage, subarachnoid hemorrhage, can be traumatic or non-traumatic. MS, multiple sclerosis, other neurodegenerative diseases like Parkinson's disease. Sometimes it's really hard to sort out if this old guy or this old gal is having stroke-like symptoms when they're on Parkinson's meds and barely able to give you a good history. Spinal cord compression up in the neck. Sometimes it can cause unilateral weakness, and that can sometimes we've seen that a herniated disc came in as a stroke and was treated as a stroke, and it wasn't a stroke; it was a herniated disc, and the definitive treatment was deferred because it was not picked up right away, and then so careful exam, careful imaging, and then it can still be confounding. Systemic infections, sepsis, and patients that come in hypotensive can have fixed atherosclerotic lesions that supply in the vessels that supply the brain, and the carotids or vertebrals. And when you get low perfusion, you can have stroke-like symptoms in those areas of watershed perfusion. So if they don't have enough cerebral perfusion pressure, they can have stroke-like symptoms. Those usually resolve with adequate perfusion. Vasculitis is another consideration. Vasculitis is a complex series of diseases that can affect the large arteries, the medium-sized arteries, and the small arteries, and cause symptoms that one of the classic ones is temporal arteritis in older patients, and it can cause headache in the temporal artery distribution. It can cause blindness, it can cause jaw symptoms, and it can be quite bad. And it's usually picked up by blood tests, a sedimentation rate that's sky high, and then they usually do a temporal artery biopsy to make the definitive diagnosis. Hematologic, we actually saw this patient in the emergency department with TIA-type symptoms. Young guy that had TTP, thrombotic thrombocytopenic purpura, and it's one of those blood disorders that causes a hemolysis, microvascular hemolysis, and then thrombocytopenia. And hyperviscosity syndrome is another thing that can happen with cancer patients, and it can cause sludging and poor perfusion in areas of the brain that mimic a stroke. Toxic metabolic, we talked a lot about alcohol and hypoglycemia. There are other things, like, interestingly enough, I had attending when I was a resident in the Navy down at Balboa, who is a ultra marathoner, and he was running, I think, probably one of his first ultra marathons, and was drinking water rather than electrolyte solution, and he got severely hyponatremic and had a seizure as a consequence of that. So hyponatremia is in that toxic metabolic, and there was another patient I saw recently that had been on Tegretol for his bipolar disorder in addition to some other medications, and came in with posterior circulation symptoms like disequilibrium, vertigo, that sort of thing, and his Tegretol level was toxic based on the new other bipolar medications he was given. So that's also in the differential. Infectious, we talked a little bit about that. I mean, there's meningitis. We used to see with, before a lot of people in this room were probably born, or we used to see Haemophilus influenza meningitis, and they'd have a brain, mental status and neurologic effects from that. Encephalitis, notably from HSV, and also from West Nile virus. Positional vertigo, we have to distinguish that from posterior circulation stroke, and that's very difficult. I mean, I had a patient delivered to me the other day, the day I was talking about, that had severe continuous vertigo, and usually continuous vertigo that doesn't fatigue, is a sign of central origin of the vertigo. And so we thought this guy's pressure was off the charts, and we thought, sure, this guy's a posterior circulation stroke. And so we did everything, and we almost gave him TPA, and in the end he had a normal CT, normal CTA, normal brain MRI the next day, and a normal brain MRA. So he really didn't have a stroke, but it's very difficult sometimes. Sometimes we will give TPA to patients that don't have strokes, and they do just fine. But we want to do that with care so that we're doing the best thing we can for the patient at the time, because if you don't intervene at the appropriate time, the consequence can be lifelong disability. So let's see. Endovascular stroke, and this is what Dr. Shano put together, and he has some images here that are kind of interesting. I'm not an expert in interpreting the images, but I'll do the best I can. So for intervention, basically a major branch occlusion. Okay. Major branch occlusions. We talked a little bit about the anatomy. Okay, so the middle cerebral artery is the artery that comes off the carotid. It supplies the major portion of the brain and the parietal and the temporal lobes, and the ICA is the internal carotid artery, and that's the basilar artery. Major branch occlusion. There's also other branches that come off the posterior circulation, the posterior cerebral artery, and one that comes off the anterior portion of the circle called the anterior cerebral artery. And they should have no completed infarct, no hemorrhage, and the time of onset generally within 8 hours of a time of onset. So these are the exclusion criteria: hemorrhage, age greater than 80 we talked about, severe medical or functional comorbidities, end-stage cancer or end-stage disease, if it may be a significant contraindication to doing this type of aggressive procedure. And IV TPA is not a contraindication, so those patients that fail TPA can go on and have this done. Inability to anticoagulate is not a contraindication. So this is basically the state of the art right now, is they have these stents, and they call them stent retrievers or stent retrievers. The one that I think George Shano is using is this solitaire device, and it's basically a stent that is self-activated once it's released from a sheath, and it basically is fed into the specific artery where the clot is over a wire, and then it's activated. It incorporates the clot as it expands, and immediately allows blood flow. The old first generation devices were like the Mercy retriever. It was kind of a corkscrew device that went through the clot and pulled it out, but there was a lot of time that was wasted because there was no blood flow during the time that the clot was being pulled out. So these are the next generation. I think there's going to be another generation, I'm sure. Basically, it dramatically improved the success rates and outcomes for stroke interventions over the previous generation. And this is an example of a thrombus being pulled out. He had a couple of cases here that are kind of interesting. There's a 62-year-old woman that was previously healthy. She had an acute onset of right hemiplegia, aphasia, and left gaze deviation, thought to be an acute ischemic stroke. Was found to be an atrial fib in the ER, so most likely a cardioembolic stroke given that scenario. She was given IV TPA, and the CTA showed a left middle cerebral artery occlusion, and I don't know if you can see this here. This is on the right. That's a good perfusion there, and there's no perfusion over here on this left side. And then he goes through and shows a few of his angiograms. He feeds a catheter up into the internal carotid artery and does an angiogram and provides the definition of the occlusion. And then he does super selective catheterization of the left MCA, and then the solitaire was deployed. And clot was removed, and then the perfusion is improved. And then you can see normal perfusion there. Final angiogram, complete reopening of the MCA branches. So a good result. Patient began moving her right arm immediately after the procedure. Later that afternoon, she began speaking and understanding speech, and her hemiparesis had resolved. Strength in speech returned to normal, and her gaze deviation completely resolved. So dramatic improvement. Transferred to the floor, started on anticoagulation, and was discharged on post-op day 4. So that's pretty dramatic. This is what can happen to a person's life when you transport, identify rapidly and transport them rapidly, and you get the system started. Case number 2, a 65-year-old white female with hypertension, prior posterior circulation, TIA, 2 weeks prior, diagnosed with a basilar stenosis. So she had been seen and evaluated and determined that she had a basilar stenosis when started on antiplatelet medication. I don't know whether it was aspirin or Plavix, probably Plavix. She was found down by her husband and intubated by the medics. And she basically had a basilar occlusion, brought to the emergently the cath lab, super selective angio, and she had solitaire treatment, demonstrated the basilar stenosis, and actually had a stent placed in the area of the basilar stenosis, and angioplasty, and resumption of flow through the basilar artery. So she had a postoperative course that was, she was extubated on the first post-op day. She was awake and following command. She had some weakness in the left greater than the right, transferred to inpatient rehab, and was ultimately living at home with her husband and ambulating with a cane with good motor strength and cranial nerve function. So that's another pretty dramatic save, starting with with the pre-hospital care, intubation, oxygenation, airway management, and rapid transport. Patient number 3, 46-year-old. I remember this patient. She came down from Harborview, I think. She had a foraminotomy, cervical foraminotomy for cervical disc disease, I think, in Seattle. She developed severe vertigo, nausea, and vomiting after getting out of her car at home, and she came immediately to the ED. Was diagnosed with a possible vertebral artery dissection. And if you look at this, I think you can see in this artery here, there's a little black spot that looks like it may be possibly a dissection point. She steadily declined, lost consciousness, intubated, and went to CTA. This time we intubated her in the ER. And she had angiography again, and found to have a basilar occlusion, kind of similar to that last patient. And so this is posterior circulation access through the vertebral arteries. Basilar artery was opened with a single pass of the solitaire, but she had a residual right posterior cerebral artery occlusion. So the posterior cerebral artery comes off that, basilar artery as it forms goes to form the circle of Willis. And then you had further runs on the angiogram, and the right posterior cerebral artery was reopened with another pass, so several passes of the solitaire catheter. So the patient woke up and began following commands, was extubated later that day, was moving all extremities and speaking post-op day 1. She was actually found to have a PFO, which is a patent foramen ovale, which is a kind of an atrial septal defect in which you can get a paradoxical stroke. In other words, you have a stroke not from the arterial side, but from the venous side. You have like a DVT or have a clot that comes up and goes through the right atrium into the left side of the heart, and then is transmitted up. So that was determined to be the cause of her acute ischemic stroke on that day, rather than the vertebral artery dissection. She was discharged, seen as an outpatient 2 weeks later, where she had mild subjective dizziness, maybe a little facial weakness and numbness, but no other major deficits. So dramatic save again. So in summary, these retrievers have dramatically improved success rates and clinical outcomes, and now you have an awareness of what's available, and we need to make sure that we stratify these patients so that we can get them appropriate treatment. And that is that.
10-minute break.
10-minute break.
Yeah, thanks, guys.
Call went out for unconscious, unresponsive 13-year-old male weighing 195 pounds. The father says that he heard a thud in the kitchen and then found his son unconscious, bleeding from the mouth on the kitchen floor. So dispatch directed him to do CPR. And then EMS arrived. No past medical history. So the crew arrived to find the patient supine on the kitchen floor, getting CPR by his father. There was blood around his mouth and broken teeth. He had agonal respirations, and he was pulseless. The initial findings, as you see them there, no obvious other trauma other than the broken teeth and blood from his mouth. So he was GCS 3, got bag valve mask, was found to be in ventricular fibrillation, and was shocked. Initially stayed in ventricular fibrillation, got an IO, epi, intubated, suctioned, and then had return of spontaneous circulation with a pulse of 150, blood pressure of 60/39. This was the initial return of spontaneous circulation. End-tidal CO2 was 30. Blood pressure is coming up without any other intervention now. Pulse is 126. And so then got sedation with Versed, a little bit hypoxic, suction blood from the ET tube, still maintaining a blood pressure, still difficult to oxygenate. More Versed for sedation, more suctioning, but still good end-tidal CO2. So the patient was transferred, was taken to Southwest, and then ultimately was transferred to Randall because of his age. So the ultimate diagnosis made on echo and on cath because of this VFib arrest was Kawasaki disease, and I'll talk a little bit more about what that is. So he had a 90% occluded LAD. Now that's related to the Kawasaki disease. He was placed on ECMO, just came off ECMO. So this was on April 20th. Just came off ECMO just over a week ago. Still in the ICU, has a trach in place, but neurologically he's following commands, getting treatment for withdrawal from his sedation. Still having some problems with lung injury, but neurologically seems to be doing well, and we're hopeful for a good recovery. So what is Kawasaki disease? No, you do not get it from riding motorcycles. So it also goes by the name of mucocutaneous lymph node syndrome, which is probably why people like to call it Kawasaki disease. It's not a diagnosis that's obviously made in the pre-hospital setting, but it's something that's in our minds in the emergency department. So it's most oftenly, the initial diagnosis is in childhood. So it's an acquired disease. We're not sure exactly why it happens. So what we need to diagnose it, we need to see 5 days of fever, plus conjunctivitis, the swollen lymph nodes. Now, we see a lot of people who have 5 days of fever, conjunctivitis, and swollen lymph nodes. But the thing that really makes Kawasaki stand out is that the patients they tend to have red, cracked lips and this red strawberry tongue. And so when we find patients like that, they're ultimately treated with IV immunoglobulin, and that moderates their response to this infection. If they don't get treated, about 1 in 5 go on to develop coronary complications. Most commonly, it's the coronary artery aneurysm. And so this 13-year-old probably had it as a child, probably never was diagnosed, never was treated. He developed the coronary artery aneurysms, and then he's had some of the other complications like pericardial effusion. He has some areas of poor wall motion. But the hope is for him to make a full recovery. Generally, kids who have this, who get treated with IV immunoglobulin, get an annual echocardiogram to make sure that nothing else is developing. But I think as far as the pre-hospital management, I mean, it's excellent. It shows what we can accomplish with good CPR, good pre-hospital care. And so this kid is not out of the woods yet, but we have high hopes for a good recovery. Questions about this case? With carpet cleaning, I had not heard that before, but it's not, the pathophysiology is not very well understood. It's the idea is that it's an overreaction to some common viral infection, and then they go on and then they attack the it's a vasculitis, so it attacks multiple vascular structures, which is why you get the sloughing in the mouth, and then you get the coronary artery aneurysm. Other questions? So case 2 is a newborn who was delivered at home. It was a planned home birth attended by a midwife. There was thick meconium present. She reported that she'd suctioned about 2 milliliters of meconium. She had been using a bag valve mask for approximately 15 minutes and was not getting improvement after delivery, and so at that point called 911. The patient was 5 days, the mother was 5 days past due, and then she had a prolonged time between the rupture of membranes. She'd received antibiotics, so a fairly high-risk birth. So the crew arrived to find the patient in the mother's lap. The patient was pink but flaccid, intermittent spontaneous respirations with the midwife assisting. So initially, pulse ox was good, 97% with blow-by. APGARs were here a little bit after 10 minutes, but reported so normal appearance, pulse above 100, no grimace, limp, slow irregular respiratory effort. So a 5 minute, past 10 minute APGAR, but APGAR of 5. A sinus rhythm on the EKG, and so direct laryngoscopy performed, and an ET tube was placed, good end-tidal CO2, suction with a suction catheter, and then continuing to suck out the meconium. Slow improvement in the APGAR with some grimace. So the patient was taken directly to Randall because, as a neonate who was very ill. It was very acidotic. Just for reference, a normal pH is 7.4. This was 6.85, so barely compatible with life. So there was presumed hypoxemic insult because of this prolonged time, so a long birth, and then a long period of hypoxia after the birth. So he was admitted to the NICU to get hypothermic treatment because we presume there was a hypoxic insult. And ultimately, the child had brainstem activity, and so was able to breathe on his own, but no function above that. And so the prognosis was very poor, and the child was discharged to hospice care. So I mean, it's when you're in this situation, it's a good case to think about and think about placing yourself in this situation. These are, I think, amongst the highest stress calls of your career. Kudos to the crew. Great job suctioning. Great job doing everything that they could to keep the baby warm. It sounds like we got involved very, very late in this case. Questions about this case? Okay. This was a case that I saw in the emergency department. So this was a 69-year-old woman who was brought in by ambulance. She said she was chasing her dog, slipped in the mud, her right knee went out. She'd had a total right knee replacement 1 year ago on that day. She had a great deal of pain. Had no other complaints. The responding paramedic noted that her knee was 90 degrees lateral. So the whole calf was pointing off at 90 degrees from the rest of the thigh when they arrived. So dislocated laterally, good pedal pulses, splinted on a scoop stretcher. Obviously, it's pretty hard to fit someone in the ambulance with the knee going out in that direction. And then very good documentation of good pedal pulses before and after the splinting on the scoop stretcher. One pearl, something that you do, because if you feel a pulse before you move it, and then you can't feel a pulse after, something that can really help you to get back to that pulse is to mark it with a pen. So provided with fentanyl, and pain improved en route. And so when we saw her, shot an X-ray, and it essentially showed when you look at the lateral view, so here's the femoral area. I'll bring up the camera so everyone else can see. So the femur was here, the tibia was over here. And she also had a fracture of the right medial femoral condyle. So our first step in figuring out, because what we worry about in a situation like this is the popliteal artery. It runs right through the knee, and it can get distracted with that dislocation mechanism. So she had pulses. So we do an ankle brachial index where we're measuring the pressure at the brachial artery and then measuring the pressure of both ankles. And so normal is 0.9 or greater, the ratio between those two. She lost pulses about 45 minutes after we got here. Gotten the X-ray, we're getting ready. If someone has decreased ABI, the next step is to do a CAT scan to see how blood flows through there. But she forced our hand. She lost pulses, and so we called vascular surgery, orthopedics, and she essentially got a bypass from her femoral artery going down to her popliteal artery. She had a great deal of swelling in that area and got fasciotomy where those compartments were opened. She was in the hospital for 8 days, but was discharged neurovascularly intact. So the pre-hospital history, in this case, we had the X-ray to help us, but the pre-hospital history is very important in a case like this because this is a really easy diagnosis to miss because, for example, you dislocate an elbow, it tends to stay out. But a knee can be completely dislocated and then can go back into more or less normal orientation. And it'll tend to be really swollen, and if we manipulate it, we find that the ligaments are all torn, but it can look pretty normal if you go out and then come back in. So often from a high energy trauma, such as an MVC or a fall from height, but as you see in this case, can occur with a ground level fall. And so posteriorly, you can get the femur coming off and get a tear in the artery here. Also with an anterior dislocation, you can just get the femur applying a lot of pressure to the popliteal artery as it runs through the back of the knee. So it's often missed. So and it's another case where both the documentation of what you found initially is extremely helpful. The documentation, finding the pulse, if you lose the pulse, noting what time, is extremely helpful in making this diagnosis. And then the last one was another case I saw in the emergency department. So the crew was dispatched for a breathing problem. A husband met the crew outside saying her lips are turning blue, and they found a 61-year-old woman laying supine in bed. She was unconscious and unresponsive, agonal respirations at about 6. He said that she was last responsive about 4 hours ago. She was just exhausted, wanted to take a nap, and then he came back to find her blue. He initially said she had no complaint prior to that. When I was able to talk to him later, he said she'd been coughing for about 3 or 4 days. History of diabetes and hypertension. So when the crew found her, about 150 kilo female, unconscious, unresponsive, flaccid, SAT was 85% initially, and initially was in a sinus bradycardia, but the rate increased with bagging. And so she was non-small, moved and dragged on a sheet into a front room to get the crew some room to work. Had BVM. She was suctioned. No change with Narcan. IO was placed. Initial blood pressure 80/32. And so then the patient was loaded for the ambulance, suctioned, and had RSI with etomidate and sucks. 7.5 ET tube, good waveform, secured. SAT at that point was 100%, entitle CO2 45. And so this lady, right after she was intubated, the SATs were around 100%. We had a really hard time keeping her oxygenated. And so despite doing everything we could with the vent going up on the PEEP, she had she braided down twice in the emergency department and arrested. We were able to get her reoxygenated, get her up to the ICU, but ultimately in the ICU they continued to have the same problem. They tried advanced ventilator maneuvers, they tried proning her, and none of those things were able to oxygenate her. And so she came in around 8 p.m. and then around 7 a.m. the family made the decision to transfer her to comfort care because she'd taken a pretty big hypoxic hit. So ultimately the diagnosis was pneumonia and severe sepsis. And then talking with the husband, it sounds like a few days of coughing. Just he wanted her to go in, she wouldn't go in, and just got progressively worse. And then essentially we just wanted to lie down. Again, another case where I think we were involved very late in the case. I think that this early intubation and giving her a period of good ventilation is probably the best chance she had. So I think the MS care was excellent here, but this is again someone who's very far along in her disease course. Any questions about this one? Okay, brief reminders about ALPS and SUDS, and then we'll get you out of here. So ALPS, the inclusion criteria are non-traumatic out-of-hospital cardiac arrest. We have vascular access and VF or VT after one or more shocks. So second shock, think rock. You cannot have had open label IV amiodarone or lidocaine use, a known hypersensitivity, and then as in almost all research studies, the protected populations are prisoners, minors, pregnancy, and then trauma deaths are already excluded. And some patients may have a no steady bracelet. So anything other than an ICD shock counts as a shock. So anything after the first shock is something that where you'll enroll someone in this study. So the goal is to give the drugs as soon as possible when you've given that second shock. Remember that anytime we open the kit, that's effectively enrolling someone in the study. So we're asking you to walk a fine line between giving the drug soon, but only opening the kit when you know someone's going to be included. That said, we'd rather have you err on the side of opening the kit early because we can account for the kit open and not given much easier than we can. We really don't want to miss people for this study. If you have ROSC and then VF and VT returns, give the remaining syringe. If it's late in the code, so say it started off in PA, then you're on down to VFib and VTAC, go ahead and give ALPS. And then if you have persistent VFib or VTAC after those drugs are given, no amiodarone or lidocaine, but you may use magnesium. Remember, you need the clear link adapter to get that. With that on, probably easiest to screw that on to the drug port. If this syringe is broken, they're obviously excluded. After you enroll, call this number, and then document when the drug was given. And then I think people have been doing an excellent job uploading this CPR process file, and that really helps with the data acquisition. Next month. Right. No, with every cardiac arrest, very, very helpful for understanding what we're doing with CPR, and extraordinarily helpful to us, extraordinarily helpful to the system. I just note when I brought this to a hospital meeting and said, I can tell you what happens in terms of the CPR on all our cardiac arrests, their mouth just dropped on the ground. They'd never even heard of this in the hospital. So you've heard me say this before. I think right now patients get much better CPR in the field than they do in the hospital. We're working on our end to fix that, but this proves the good work we're doing. So hopefully next month, first Tuesday, is the next scientific review committee meeting. We should have some interim results. Okay. And then finally, sudden unexpected death study, or SUDS. This applies to transport agencies. So this is all patients with pre-hospital cardiac arrest, not in a known traumatic violent death or known overdose. And this is blood that's drawn after the IV or IO start. As a reminder, the goal of this study is to get these genetic markers so we can understand who is at risk for sudden cardiac death. The tube gets labeled, your unit number, the date of service, hospital face sheet if you have one, and then placed in the ambulance cooler, and then into the refrigerator at the transport agency station. So with that, I'll be around after for any questions, and thank you very much.